I invite Dr. M. Swamikannu Murugan, Director of Internal Medicine, MGM Healthcare, and Chairperson for the session, and Dr. A. Natarajan, Senior Consultant Diabetologist at his own center in Anna Nagar, Chennai, and Chairperson for the session. May I request Dr. Swamikannu Murugan to please come forward and introduce the speakers. Please put your hands together and welcome Dr. Swamikannu Murugan. Thank you.
I think at the outset, I would like to thank the D Club for organizing DCCon 2026. And we are in the pursuit of empowering, elevating, and excelling in our field, in the field of medicine. Like Dr. Natarajan said, learning is a responsibility. So very nicely he said. And we'll start the session with none other than Dr. Paranthaman. Paranthaman is a very close friend of mine, and any conference in Chennai, it will not be without Paranthaman. And he has got such a it's very difficult to find people who shine in both academics as well as in clinical practice. He is one of those rare species. We are very lucky to have for the DCCon conference. He'll be our opening batsman. He's going to deal with the subject cough. Cough is a very common problem for which people approach us. It can be from it's a very vital symptom because it can clear the secretions from the respiratory tract, effectively preventing further infections. The one symptom and many diseases we have different types of cough: wet cough, dry cough, brassy cough, post-tussive cough. So I can go on telling, but I'll leave it to Dr. Paranthaman. I'm sure he will make it very interesting, the cough subject. Thank you for the opportunity. Dr. Paranthaman will take over from here.
Thank you very much, sir, for your kind words of introducing me with a pleasant introduction. At the outset, I'd like to thank the organizers, Dr. Natarajan sir, who's the secretary, and founder president, Dr. Dhanavadan sir, and our team for having given me this wonderful opportunity to talk on the common symptom, the cough, types of cough, and management of cough. I think everyone know a cough, everyone know to treat a cough. I just highlight about what are the common symptoms and how to approach the cough. We all know the cough is a number one symptom in our clinical practice, in a day-to-day clinical practice. And it was estimated that 10% of the adults across the globe are suffering from chronic cough. Then what is cough? Cough is a forcible expiration against a partially closed glottis following stimulation of the cough receptor in the respiratory tract. Why the cough? Is cough is good or bad? If you get more full cough, is bad. Good cough is good. How cough is good? Cough is a protective response. If there is no cough reflex, you develop pneumonia, you develop all complications, all aspiration pneumonia, and then of course the lung flooded with the fluid. So they succumb to any complications or disease following respiratory illness. So it forcibly excretes out the secretions, and foreign body expels out the foreign body. So, but mediator is a vagus nerve. So vagus nerve is which stimulates the cough reflex and expels the foreign body inside the respiratory tract, so that the inspiration and expiration is normal. And what the disturbance is due to? If you have persistent cough, you have sleep disturbance, social embarrassment, sometimes urinary incontinence, and musculoskeletal pain and fatigue. All these are the simple complications of the cough. What are the common types of cough? We have several types, we will discuss it later. What are the common types of cough and how to approach it? The first most common is a viral infection, following cold, running nose, cold cough, and which is the most common is acute onset. Till yesterday patient all right, suddenly durable cough, running nose, cold cough. And it might be initially it's a dry cough and progresses to the productive cough, and its self-resolution occurs in 1 to 3 weeks. That's why most of the time we don't give much importance to cough, because the self-resolution occurs, because viral cough, it subsides by itself, and we sometimes, most of the time, we may not take medicine at all. There are certain types of cough following viral infection. It damages the respiratory epithelium, exposes neoendings to the environment, and even the simple allergens like a dust, smoke or cold, it stimulates now, puts a persistent cough, it's a prolonged cough. So what initially a short duration become longer duration, and usually associated with the sneezing, running nose, cold, this allergic cough. So anyone who having a running nose, sneezing, allergic cough, anyone acute onset cough is a viral cough, and those who are asthmatic cough, where paroxysms of cough and nocturnal exacerbation, and the cough is associated with slightly wheeze. Again, they respond only to the bronchodilator. The first one, no treatment; second one, anti-inflammatory; third one is bronchodilator. See the different type of cough management in all the states. And fourthly, the GRD. GRD in those days when we studied, we never focused on GRD at all. In 20 years ago. Now the GRD cough is more common because of the lifestyle changes, obesity, and all other less inactivity, and this acid reflux into the esophagus stimulates the cough. Even if you whatever the bronchodilator, anti-inflammatory, nothing will work out except the acid suppression. Then third thing is the whooping cough, pertussis. Some that now pertussis no more is very common, but rare do occur, and that is again you can prevent by vaccination. And at another problem is a drug-induced cough, ACE inhibitor cough. Nowadays, people are using ACE inhibitors for hypertension. 1/3 of the population of the world are hypertensive. They are taking ACE inhibitors that can have cough, so you have to load that cough. Apart from that, what is more interesting is the ear is often the first diagnostic instrument in cough. Like a stethoscope, ear is an instrument for cough. How does? See, just listen to the cough sound. You make the diagnosis. Where is the problem? What is the problem? You can treat all of them. So what is that? Barking cough. Barking like a dog. So it's a barking like a dog. That cough is a laryngitis. You just make a diagnosis of laryngitis. Sound, you make a diagnosis of laryngitis. Husky cough. Laryngeal involvement, inflammation. Again, we associate with hoarse voice. That is called laryngitis. So laryngeal edema, laryngitis. Brassy cough, as our chairperson already mentioned, is a metallic, high metallic sound, persistent, harsh cough, is a sign of tracheal compression. It is not a viral cough, it is a sign of tracheal compression, it is a tracheal tumor, retrosternal tumor, suprarenal tumor, and sometimes aortic aneurysm. See that the tone of the cough will tell you what is the diagnosis. Then bitonal cough, the two tones in a one cough, that is called bitonal cough, that is getting partial paralysis of the vocal cord. So one side good sound, other side low sound, so that's called bitonal cough, and that's bovine cough. Low tone. I think most of you heard the bovine cough, low tone and long duration. That's a particular cough is very sign of recurrent laryngeal palsy. So you can tell the recurrent laryngeal palsy just listening to the cough. It's very difficult to diagnose clinically other than that. And whooping cough, repeated cough, and pertussis, hacking cough. Hacking cough is typically in smokers and those who are in GRD can persistent dry cough, hacking cough. That's irritating cough. And staccato cough. Staccato cough is a machine gun-like cough. It's a rapid repeated cough. It's in chlamydia. Chlamydial respiratory infection is very less common, but still, if you get a staccato cough, you can make it. Paroxysmal cough. In paroxysmal cough. It's non-stopping cough. Bronchial asthma. Then wheezy cough. Bronchial asthma, COPD, foreign body. Then nocturnal cough, asthma. Morning cough, COPD. Positional cough, bronchitis. So many diseases can be diagnosed just listening to the cough. Friends, recognition of these characteristics of the cough can rapidly narrow the diagnosis, narrow down, guide this investigation to a limited extent, and it diagnose, prognosticate, and treat if you listen to the cough. Then all the clinical assessment, of course, you know that history, examination, and the history, duration of the cough, timing of the cough, triggering factors, Triggering factor is very, very important, and sputum color, medications, was there any medication, especially ACE inhibitors, beta blockers, and smoking history is a very important history to analyze the localize the cough pathology, and vital signs. So you see SpO2 is low, cough, pulmonary edema or pneumonia. Then ENT, you have to road post-nasal drip, ENT, you have to load, and chest bilateral auscultate for a wheeze, rolls, and it is a reduced breath sound. And then abdomen, you have abdomen, epigastric pain, cough, epigastric pain, GRD, and clubbing. If you have persistent cough with the clubbing, think of malignancy. You can just make a diagnosis of malignancy looking at the cough and looking at the clubbing, and of course red flag sign, hemoptysis, weight loss, and signs for a malignancy. And see that now the question is that GRD is a GI problem, esophageal problem, gastroesophageal problem. How does it produce cough? What ways connect to a lung to produce a cough? It can produce abdominal pain, it can produce abdominal distension, it can produce discomfort. How can it produce cough? Yes, there are two mechanisms. One, the direct connection and indirect connection. Direct connection is the reflection of acid, damaged, and it goes micro aspiration to the throat and goes to the trachea and produce a cough receptor. That's one can produce. Second thing is indirect vagal reflux. There is nociceptive reflux on the esophagus. If acid reflux is there, damage the nociceptive reflector, it triggers the vagus nerve, go to the brain, vagal center, produce a cough. So the different types of mechanisms of cough is there. So how the acid reflux to cough? This is that one, as I already told. If acid is reflux into the esophagus, it relaxes the lower esophageal sphincter. Again, further reflux, nociceptive receptor stimulation, damages neuron endings, and stimulation through the vagal nerve. That's what I already alluded to. And of course, chronic inflammation of the nerve. This is called hypersensitivity. So you see the bronchial asthmatics are having more and more because of the hypersensitivity, hyperreactive bronchus. Similar to that, GRD also hypersensitive, hyperreactive because of the inflammation in the esophagus connected to the bronchus. That is the cause. So these are the areas we work at. Then if such a case is there, how to approach cough? The approach is 4-step approach. First step, you identify and determine whether acute cough, subacute cough, chronic cough. If it anything less than 3 weeks is acute cough, it fit into the viral infection or self-limited and disease, a post-nasal drip, all these things, sometimes maybe allergic bronchitis also. If anything between 3 weeks to 8 weeks is a post-infectious cough, especially viral infections, and whooping cough may be very common. Sometimes resolving pneumonia, it may be there, and it warrants investigation. So any cough more than 3 weeks warrants investigation. And chronic cough, very common with asthmatic, COPD, upper GI, the respiratory tract infections, and ACE inhibitor. So don't forget to ask the history of a drug, especially ACE inhibitors, this enalapril or ramipril with, and again beta blocker, and sometimes it may be a cough due to lung tuberculosis or malignancy. The second step is that step 2 is a productive cough or dry cough. If it's a productive cough, that means there is a secretions are more and is associated with the bacterial viral infection, and the secretions are more with the pneumonia, bronchitis, bronchiectasis, COPD. So you need to evaluate, need to investigate and treat the patient. Then if it is a dry cough, again there is no mucus produced, only irritation, again very common with viral infections, bronchial asthmatic, COPD, allergies, drug induced ACE inhibitors, GRD, dry cough, interstitial lung disease, dry cough. If you have severe violent extensive extensive rods, but auscultate, but only dry, no secretion at all, is interstitial lung disease. You can make a diagnosis of interstitial lung disease, just auscultate, violent extensive rods, but no secretion, ILD. So that's the thing. Step 3, look for warning signs. Let us not imagine or take it that is a viral infection, simple infection, don't neglect it. So look for the warning signs. What are the warning signs? Anyone comes with the blood in the sputum, anyone comes with difficulty in breathing, anyone comes with the chest pain, then high grade fever, rapid progression, breathlessness, of course you think of the voice change, you think of the warning sign of underlying severe disease. So according to that symptoms, you can localize the disease, what's the pattern. The step 4, having diagnosed is something, warning signs are there, is maybe something organic, you go for an evaluation of the patient with the cough. Step, there is a level 1 investigation. Basic, straight away don't go for a CT chest. Take X-ray, chest, CBC, ESR, CRP, and of course sputum examination. Flowmetry you can do, peak flowmetry, but asthmatic you can do it OP. This is the first line investigation. Then if it does not give clue, you go to the second line investigation. If the cough is persistent, it is especially more than 3 weeks, you get CT chest, HRCT to rule out bronchiectasis and malignancy, and CT paranasal sinus, and sometimes 24 hours urinary pH of the stomach that might give clue whether it is a GRD. Third step is a specialized investigation like bronchoscopy, bronchial provocation test for bronchial asthma. Of course, you can do the laryngoscopy and reflex sensitivity. So you specify or go by the levels of investigation as per the symptomatology and severity and the duration. Step 4, treat the underlying cause. Cough therapy is not important. Giving antisuppressant of the cough and giving antiprotective or mucolytic, no use. What is the best treatment for cough? Treat the cause. That's the best treatment. What are the cause? If a bronchial asthmatic is there, don't give cough suppressant. Give inhaled steroid and bronchodilator. That's all. That is the solution for it. Then if you have COPD, again bronchodilator, smoking. If you smoker, smoke cessation is very important. Pulmonary rehabilitation you have to do. GRD, acid suppression. Don't give cough suppressant. Don't give anti-inflammatory. Don't give bronchodilator. Give acid suppression. That's the treatment for cough. And of course, infections, you have to give antibiotics. ACE inhibitor, stop the ACE inhibitor. That is the treatment. No need for suppressive, antitussive drugs and bronchodilators. Of course, bronchiectasis, you need to give bronchodilators and antibiotics. And see, cough has got its own complications. There are 5 B's complication. Just cough complication. What are complication? B is, first B, it will break the ribs. If a cough is forcible, it can compression of the chest, it is to fracture of the ribs. 9th, 10th rib very commonly affected, and sometimes 5th rib also. It will break the rib, sometimes break the vertebra. In already this really frail patients, it is possible. Then bleed. See, most time I have seen in younger individuals comes with persistent cough with the subconjunctival bleed. That's bleed, not only subconjunctival, retinal bleed, rectal sheath bleed, hematoma, sometimes forcible cough, then produce hemoptysis. The third B is blackout, cough syncope. They cough, suddenly lose consciousness. Then all the patient, attenders, everyone rush into the hospital, so unconscious, some fits like this. It is only a cough syncope, just treat the cough, and some urinary incontinence there. Bulging, not only thus, it will bulging, that means you can have hernia, persistent cough for longer duration, they have hernia, pelvic organ prolapse, and stress to incontinence will be there. Then burst. So persistent cough, especially chronic asthmatic and COPD, so forcible cough can have pneumothorax, pneumomediastinum, a rare diaphragmatic, and rarely esophageal rupture can occur. So such a forcible cough can do anything. So be careful with the cough. Then management principles are simple. Is general measures. Then is a productive cough, dry cough. What are general measures? Any cough, sometimes commonly is the irritation and mucus. The secretion is mucus thick. So hydrate the patient. Then give some honey, not less than 1 children, 1 year of age, and adults and children more than 1 year you can give. This is a low engine effect. There is soothing effect will be there. And the humidified air, you can give steam inhalation. And of course, you give elevate the bed. A person, especially who is having cough, when a persistent cough is there, it reflects into the esophagus, it produces a GRD cough, so elevate the bed end. See that these are the general measures for all cough. Then, if it is a productive cough, you give expectorant, guaifenesin is a mucolytic, and steam inhalation is useful, plus chest physiotherapy, and treat the underlying cause and avoid cough suppressant. If the productive cough is there, avoid cough suppressant, like dextromethorphan, it is centrally suppressing. And if it's a dry cough, give cough suppressant. See, one area you give cough suppressant, other area don't give cough suppressant. Dry cough, suppress a cough, give dextromethorphan. Productive cough, don't give that. It is contraindicated. Not contraindicated, but it is not advised. So, antihistaminics for allergic cough, then GRD, of course, you have to add acid suppression. Especially you ask a patient for only drug is ACE inhibitors, ERBs, so that it will prevent the cough. What are treatment strategies? Again, treatment strategy depends on the cause. So, if you have upper respiratory infection, you give antihistaminic. There is the first generation antihistaminic like chlorpheniramine we can give, and inhaled corticosteroid can give if it is upper respiratory tract infection causing the problem. If it is asthmatics, inhaled corticosteroid mainstay, and give bronchodilator, short-acting, long-acting bronchodilator, and muscarinic receptor, and then leukotriene receptor antagonist also can give. If it is GRD, you give anti-acid suppression, but in GRD, the acid, there is anti-suppression should be a higher dose. Like you give for acid suppression for peptic ulcer disease, you don't give that, you give twice the dose, two times a dose, 40 milligram BID, like that. So not the ordinary conventional dose. You increase the dose, especially CRD, for 8 to 12 weeks. Only then everything, the inflammation will settle. So if it's a chronic bronchitis, then the COPD, stop smoking, give antibiotic, give LABA, and the short-acting bronchodilators. Antitussives. Most of the time, cough syrups will have antitussives. It's basically centrally acting dextromethorphan. It is centrally acting medicine. It acts on inhibiting the NMDA receptors, and thereby it suppresses the cough. That can be given, but caution should be the serotonin syndrome is very common, so be careful with that. Codeine again is opioid antitussive. It is sedative, and it can produce constipation. Be careful in elderly. And the one important drug what I realized is that there is gabapentin and pregabalin. These are the neuromodulators. I never had before preparing for this lecture. I do not know that the gabalin used for the cough. It is acts a neuromodulator center. So it is very useful. That can be given. And amitriptyline. Yes, most of the time chronic cough, especially in female, amitriptyline neuromodulator acts on the cough center, and of course speech therapy you can give. So special situations, children, elderly, pregnancy. Children be careful, but certain things are not should not be given. And risk elderly, aspiration is very common, ACE inhibitors. Pregnancy, be careful. Avoid codeine. Codeine, it will cause neonatal withdrawal risk, so better avoid codeine in pregnancy. And safer is honey, steam inhalation, saline irrigations. And of course, budesonide is safe in pregnancy. GRD, alginate. That is like Gaviscon, like this thing you can give, and PPI if necessary, if severe you can give. So pregnancy you ought to be very careful. And friends, the take-home messages are: they determine the duration of cough. Is acute cough, subacute cough, chronic cough. If acute cough, no problem. Subacute cough, investigate. Chronic cough, be alert. Screen for the red flag sign at every visit. Suppose a patient comes to the cough for 1 week, you look for a red flag sign. Like what red flag sign? Is there hemoptysis, chest pain, breathlessness, or clubbing, incidental or associated? Yes, look for it. Then is there history of weight loss? Yeah, weight loss, elderly man, weight loss comes to the cough. Be careful, that is malignancy. The day one you make a diagnosis of malignancy. Then acute pressure, presumed viral. If it's acute, presumed viral infection, just treat with antibiotics and supportive measures. Chronic, maybe the bronchodilators you can give for asthmatic and acid suppression. Review medications. You ask the patient what are the medications you are taking. Yes, ACE inhibitors or beta blockers, maybe that you cut down it, and of course escalate to CT spirometry and bronchoscopy if the patient is or failed to produce empirically treatment. Thank you very much for patient listening. Thank you, friends.
Thank you, Paranthaman. Very sharply you finished in time.
Yes,
thank you very much.